So, welcome to this 95th medical education seminar in Tokyo University. Today we will welcome Professor Linda Snell from McGill University. She's coming here as a visiting professor for 4 months. So she has been director of the Medical Education Center in McGill University, or the director and professor of General Internal Medicine in McGill University, and also worked as the board member of Canadian Medical Education Academy and so on. And also she is a co-author of a very important and famous paper of competency-based medical education. So she is very famous in medical education field in the world. And she is right now the chief of our search committee, the selection committee for our visiting professorship. And she is the first visiting professor who has the second attachment with our center. So she's the guru of gurus right now for us. So today's topic is future directions in medical education, new models of medical education. We will have a very nice talk.
Thank you very much. Is this working? Yes, it is working. So, first of all, thank you very much, Honey Sensei, because I'm thrilled to be back here, and it's lovely to see familiar faces and to be in a place where I already feel at home. I will caution you, you did mention that we've written a paper on competency-based medical education. There was a whole series in Medical Teacher 10 years ago, and there's another series coming out within the next few months in Medical Teacher to update that. So whatever I say in medical education tends to be biased towards talking about competency-based education. Having said that, this is a 4-lecture series. I think it's okay. And in this series, what I like to do is do a little bit of an overview looking at the challenges and the problems with our current models of the way we teach medical students and residents and ourselves, and how we assess them. And then what I'd like to do is look at the approaches we use and see if there's anything that we might do a little bit better in terms of teaching, in terms of assessment, and in terms of evaluating our programs. And I'm really hoping that by the end of this 4 series, you will have a pretty broad overview of what's new in education. And I'm hoping you'll be able to use some of this in your own work as a teacher and an educator to actually change and improve the education for medical students and residents and ourselves in Japan. Just before we start, maybe I can ask you, how many of you are practicing physicians, clinical teachers? Please just put up your hand. Okay? How many of you are postgraduate trainees, either residents or graduate students? Okay? Medical students? Okay, who am I missing? Anyone else?
Engineering, bioengineering.
Thank you. I don't think I've ever had one of those in one of my lectures, so it'll be interesting to see what questions you come up with. Thank you for being here. So the 4 topics that we're going to be going through over the next 4 months are, first of all, new models of education, then delivering and designing innovative curricula, looking at assessment, how we actually evaluate our learners, and then looking at whether these new models really work. Is there any evidence for that? So the first lecture is going to be today. But before we start, I'm sure you're all wondering what I've been doing for the last 10 years. Well, a couple of you sort of nodding your head. So I was here 10 years ago, exactly. And since that time, I've been doing a lot of presentations, pretty well all over the world. I've been doing workshops, faculty development, been to the Middle East, running a conference in South America, and ran a conference in Saudi Arabia, Australia, all kinds of interesting places. And what I find interesting is that many of the skills and the abilities that I actually needed to do that, I started to develop, or I continued to develop them when I was here as a visiting professor. So thank you very much for that. That made a change in my career. It hasn't all been work. I don't know if you can really see this from the back, but we've got me snowshoeing, I was skiing here, drinking some wine. That was a bike trip, I think in France, some traveling in various places. This is making maple syrup. We went to visit Downton Abbey, for anybody who knows that. So these are, I'm lucky enough to be able to mix my work and my play in a very enjoyable way. And I've become aware of this as we speak more and more about wellness in medical education. So enough of that. The next thing I thought I'd do just before we start the lecture is actually look at the lectures that have been given at IRCME since I was last here. The formal topics, the formal lecture series started in 2008, but I was able to get some topics since I was here in 2006. And I managed to do a very deep analysis of the topics, basically by putting them into a word cloud. And what I'd like you to do when you look at this word cloud is think about what you see, but also think about what is not there, or what is underemphasized. So the way it works is you input the titles of all the lectures, and then the size of the word that comes out is the frequency of that time that topic appears. So here's the cloud. You may not be able to see it from the back, but I think you could probably see it on your handout, even if you can't see it from the back. So my question to you is, what do you see? What strikes you? What stands out as being present, or perhaps underrepresented, or absent? I'll give you a minute or so to think, and then maybe we can talk. Anybody have any, thank you, that could go on for now. Anybody have any comments or thoughts? I know it's horrible, because all these North Americans come and make you talk at the end of the day, right? And that's not very Japanese. Does anything surprise you by its presence or absence? Sam Sensei, I think I'm going to pick on you. Do you see anything? You can see it on your handout easier, but do you see anything that, this is just the topics of the previous lectures?
I think most themes are very reasonable, and now we are very interested in competency-based curriculum or assessment aspects, so it seems very reasonable.
Yeah. So, yeah, a lot of the things we see here, curriculum, assessment, evaluation, teaching, students, I would expect to see in a lecture series about medical education. Oni-sensei, you'll be pleased to see that reasoning was quite well represented. I know that's an interest of yours. There's a few things, though, that I think are a little bit underrepresented when we think about what's new and what's hot in medical education. For instance, and I have to look at this because it's very small too, there wasn't all that much on education research or scholarship in education. Though there is the word patient in there somewhere, but it's very, very small. So the patient perspective in education is a big topic in some parts of the world right now. It doesn't seem to have been a big topic with our lecturers. Preparation for practice, transitions into practice is another thing that's not well represented. Quality, both quality of care and the link of quality of healthcare with quality of education. And also leadership and leading change, and lifelong learning. Those were the things that struck me as things that were a little bit underrepresented in the lectures that were given here. Now, admittedly, these were lectures, many of which were chosen by just the individuals who happened to be here. They weren't invited to come and give a lecture on something. But if you're going to invite people to give lectures, there's a few underrepresented areas that I think would be interesting to pursue in the future, because those are areas where there's a lot of new work going on in medical education. All right, so it's now 10 minutes past, and I've been entertaining you for the last 10 minutes, but we have quite a few more people in the room now. So I think we can start the presentation. I will tell you that I do tend to stop sometimes and ask questions of the audience. I'm warning you. There's a prize if you answer first. Okay? So just to warn you that you can get a prize if you answer first. I didn't give one to San Sensei because I work with it. What we're going to talk about over the next hour or so are some new models of medical education. And in particular, we'll start with our current models and look at them and see if there are any problems with the way we're doing things now and whether we need to change. Then we'll think about some newer models. We're going to look very briefly at 3, and then we're going to look in a little bit more detail at competency-based medical education. And not just from the description of it, but talk a little bit about what's going on around the world and some comparisons of competency-based education around the world. And then I'm going to try and apply this and ask you to help me apply this to the situation in Japan, to see if it's relevant for you, and to see whether you actually feel it might be something that's useful here. I won't be going into that much detail on the how-to of competency-based education in this talk. I'm hoping to do that in the next talk. So let's start off. Now we'll dive right in. Are there problems with our current models? So what are we doing now that works? And what do we do now that doesn't work very well? So let's look at the classic traditional model of medical education that many of us trained in. Certainly anybody who's got a bit of gray hair will have trained in. And depending on where you are in the world, either it's a 5 to 7 year program that students come into out of high school, or it's what's called a graduate entry program that's much more common in North America and is becoming common in some parts of the rest of the English-speaking world, Australia and England in particular, where students have done either an undergraduate degree or at least 2 or 3 years before they actually enter medical school. One of the main characteristics of this model is that there's preclinical and then there's clinical. And there's often a wall between them. You do your preclinical, you don't see patients, and you sometimes don't even hear about patients. And then you do clinical, and nobody talks about all that basic science stuff that you were supposed to have learned before you came to clinical. Preclinical is usually done in a classroom. It's done in large groups. There may be laboratories. There are written exams. These days there may be some online learning as well. Clinical is done in a big teaching hospital, and traditionally the role of the student was that of an observer. And the exams were still written exams, mainly based on knowledge. So that is, it's called, does anyone know who that is, that picture? Flexner, excellent. I'm gonna have to give you a prize. A McGill pen. I can't get over there, hang on a second. How are you? Nice to see you. Okay. So Abraham Flexner was a teacher, not a physician. Back in the early 1900s in the USA, when they had far too many medical schools that weren't producing good quality doctors. And he came up with this model of 2 years of preclinical, 2 years of clinical, and then out into practice after a residency, which we'll talk about in a minute. And that model was actually in use for many, many years. It was, however, teacher-centered, very much based on the transmission of knowledge, of which there wasn't very much back in the early 1900s. Very discipline-based. The anatomy department didn't talk to physiology, didn't talk to biochemistry. I'm not even sure there was biochemistry there, but certainly anatomy didn't talk to pharmacology. And in the clinical world, the surgeons didn't talk to the physicians, to the obstetricians. It was very oriented to big teaching hospitals. The program was standard, there was little flexibility. There was a core and maybe some electives as time went on. But what you learned was very opportunistic. It was almost an apprenticeship. If you were on a ward and there were no patients who were on digitalis or who had an appendix that needed to come out, you didn't learn about that. So fast forward 70 years. And a couple of things happened. Ron Harden published a very seminal article called the SPICES model of curriculum in 1984. And SPICES because of the first letters, student-centered, problem-based, integrated, community-oriented, and systematic. And this really was a nudge to people to say what we're doing may not be right for now. And about the same time, in the late 80s, something called the GPEP report, the General Professional Education of the Physician report came out by a large American group, the Association of American Medical Colleges, very influential, that basically said the same thing. We're not educating our medical students, or for that matter, our residents, as well as we could be. So things started to change, and many of you who, again, may have some gray hairs, and even some younger ones, will remember that in the 80s and 90s and the early 2000s, things started to change. And these are the types of models and things that started to happen, some of which are being used in your own universities. Problem-based learning started first at McMaster in Canada, in my country, and at Case Western in the US. And now pretty common. Some schools have gone totally problem-based. The last time I was here, Tokyo Women's was, I think, fully problem-based right from the beginning. Other schools have chosen to just take parts of their curriculum and make them a problem-based model. case-based learning, particularly for students who are in the preclinical years, so that they get to see the relevance of all of that biochemistry and physiology that they're learning. Peer learning. Who would have thought that actually peer-to-peer, medical student to medical student, teaching and learning would be effective? But it is. It's very effective. Sometimes more effective than us as teachers. Team-based learning, same thing applies. And there are very specific models now for team-based learning. All of these meant that the students were involved in very active learning and often working in groups as opposed to the classical Flexner large classroom type of things. And we know, of course, from medical education theory and principles that active learning means people learn more. Integrated curricula. Now that's been taken to mean a number of things. In my own medical school at the University of Alberta, I won't tell you how many decades ago, we were actually doing that. Instead of having anatomy, physiology, biochemistry, pathophysiology, etc., pharmacology, we went by systems. So there was a gastrointestinal system where we learned all the anatomy, physiology, etc., as well as the clinical presentations at the same time. It was integrated. And then we went on to another system. This was all before we actually got onto the wards. But we did get a chance to see patients, even though it was in an observation capacity, very early. And what's next here? Spiral curricula, basically revisiting as you go on in time at a higher level the same topics where you add in more and more detail and depth. And the concept of early clinical exposure. In my own medical school that I work in now, McGill University, our students actually start seeing patients in their first year. Now, clearly they're not doing histories and physicals. A, because they don't know how to do them. B, because they haven't learned the appropriate medical stuff. And C, because they're still pretty young. They're not necessarily fully formed adults. But they do learn how to talk to people. And they do learn how to get information and be professional and learn about the patient and all that sort of thing as they see patients in their first year. Once students hit clinical now, and in some medical schools, that's now fairly early. That's in a 4-year school, could be at the beginning of second year. They may have a junior clerkship where they do observation and histories and physicals. Clark, a patient is called. It doesn't count. It's not something that goes in the medical record. But once they become more senior, often in 3rd year and 4th year, they are a fully functional part of the ward team. They do histories, admit patients, do minor procedures. If they're in surgery, they'll go to the OR to assist. If they're in medicine, they might do a lumbar puncture or something like that. And the expectation is that they actually act as the patient's doctor, clearly under supervision. And as with your students here, medical orders have to be signed, and anything that's new to the student, like a procedure, has to be supervised. But they have very much more hands-on experience. It's not just in teaching hospitals. In many places, it's moving into the community, into the outpatient setting, to see the 90 to 95% of patients that never make it to the hospital. Because that's what most of them are going to see in their practice. Concepts such as interprofessional education, learning with students from other professions, being taught by other health professionals, having a nurse teach a student how to do a venipuncture, having a midwife or an obstetrics nurse teach a student how to deliver a baby would be typical examples of that. The programs are much more flexible. There's a chance for students to do electives in things that they're interested in. Simulation has been around for 10, 20, 15 years, and most places have an active simulation program for medical students to make up for the gaps of things they haven't seen. And evaluation, or assessment rather, is no longer just by a written exam, but very often based on clinical performance and OSCEs. Now this should sound familiar to you. I know you're not all from Tokyo University, and I'm sure that in your own universities you will have seen or experienced some of this. So what's the problem? This is what we're doing now. What's the problem with it? Think about that. What happens in residency and postgraduate education? It's still pretty well an apprenticeship where people learn by doing, they learn in the workplace, and you're assigned for a period of time to a rotation, or in Britain they call it a firm, and in that you're expected to learn by doing. You are supervised, and the supervision gets more and more distant as you get more senior. There may or may not be a formal curriculum to go along with this. In North America, there tends to be something we call an academic half day, where the residents are excused for 3 or 4 hours and go and learn some formal things. In many other parts of the world, that doesn't happen. The concept of core competencies, things that every resident, every doctor needs to know that may not be related to the actual discipline area, also comes up. Communication skills, leadership skills, teamwork, things like that. The assessment of residents is often done in the workplace, although there may well be a final examination that could be a clinical or a written exam before they get out into practice. Fairly common model throughout the world. In Europe, there tends not to be the assessment, but there tends to be the attachments to a particular clinical area for a period of time, and you go through a series of those. Okay, you don't get another pen, but who's this guy? Anyone recognize him? This is William Osler, okay? So it's said that if you should take William Osler, who was a very famous internist teacher back in the late 1800s and early 1900s, if you took him and put him on one of our clinical teaching wards today, he would not recognize the system, the way we treat patients, the medical side of things has changed tremendously. But he would clearly be very comfortable and recognize the way we teach residents. It hasn't really changed in the last 100 years, which is interesting. So the question is, do we need to change? Some of you here may say, I worked out okay. I went through that system. I can practice, I'm competent, so why do we need to change? So let's talk about that for a minute. I'm going to read this to you, but there's some underlined parts that are the important parts. This is from a document put out in the UK about 10 years ago, talking about quality care, and it's linked with education. It says the medical curriculum, in this case they're talking about medical student curriculum, should be designed to provide opportunities to acquire independent learning skills. You have to learn how to learn, while developing clinical competence to a level appropriate to a new pre-registration house officer or intern or junior resident, depending on where you're from in the world. Experiential learning, learning from experience, learning by being in the situation, arising from periods of direct patient contact is essential. You can't learn medicine from a book. I think Osler said to learn medicine, to learn medicine from books is like not going to sea And to learn medicine without books is going to see but without any guidance. I'm paraphrasing that. They also suggest that skills labs, which in these days we would actually say simulation centers, learning activities using simulated patients are important. And you have to see patients in all different kinds of settings, primary, secondary, or tertiary care, for face-to-face contact. Amongst other things, and I know there are people in this room who can confirm this is the case in Japan, if you don't see patients in primary care, it's unlikely that you're going to want to go into primary care. So it's important to give learners the exposure so they can decide where they're going to want to go. So I think what this statement is saying, and what others have said at all levels of medical education, is that there are challenges and problems with the way we teach now, and the way students learn now. Sure, they turn out okay most of the time. Maybe? Let's have a look at that. Here are some of the challenges that I think we have. The first thing is that our knowledge and technology is exploding. What you learned last year is no longer relevant. We all know that. And it used to be that there was a turnover every, 5 years, and then it was 4 and 3 and 2, and now it's last week. So we have to teach students how to learn how to learn. There's a huge concern about patient safety and medical error from two perspectives. One, from the learner perspective, if we've got medical students now, we're saying you must go on the ward and do these things, or even residents who are doing these things, is it safe? Are there going to be more errors? And the second is, when these individuals go out into practice, are they going to be safe practitioners, and how do we know they're going to be safe practitioners? Same thing about quality of care. In North America and in Europe, there have been comments about poor coordination of care, inappropriate use of tests, dysfunctional collaboration, bad teamwork, all of those sorts of things which lead to poor quality care. Certainly the last time I was here, I haven't been able to figure it out this time, but the last time I was here, those issues were the same here. Let's look at the learner now. You put them on a ward or even in a clinic or somewhere for a period of time, and you hope that they get to see and deal with the medical problems that they're going to see in practice, but there's no guarantee of that. The patient mix, particularly in large teaching hospitals, has changed over the last 30 or 40 years. People no longer come into hospital for many, many illnesses than they used to in the past. And you really can, by chance, miss out on treating a heart failure or delivering a baby or whatever, if that's the way it is, that's your luck. So you could actually graduate having gone through the appropriate period of time, but not having seen some important basic things that you need to learn about. The other thing with our systems now is they don't address transitions. That important transition of going from being a resident into practice. For those of you who are in practice now, do you remember your first few days or weeks or months as an independent practitioner? At least, well, I was pretty scared. I thought, my goodness, nobody's looking over my shoulder anymore, making sure that I'm doing things right. There's also transition from being a medical student to a resident. I was talking to a medical student just a few minutes ago who's going to be a resident in a few weeks, I guess in a few months. And she said, I'm going to be able to write orders and nobody's going to be countersigning. That's a bit scary. Patients and the public have concerns too. They have concerns about doctors graduating without the compassion they'd like, without the communication skills, perhaps without some of the professionalism that they expect. So this is a public concern. The bottom line is that there can be many who graduate who are wonderful doctors, but it's not even. There's an uneven product, and there are graduates who get out of medical school and residency with deficiencies, and our training models don't allow us to address these, except if they're so bad that they fail. And very often, these people have good knowledge base, so they'll pass a written exam. So you don't really know if they're really good as practitioners. So here are some problems with our current models. In fact, if you look at what happens in practice in our current model, you'll see that we learn and our performance gets better, and the expectation is that it will keep going up over time if this is the acceptable performance. And you get a piece of paper that says, I'm certified, and so you think, I'm there, I'm good for life. But in fact, what happens is you forget things, or more importantly, times change, technology advances, knowledge explodes, and your performance and your competence goes down. And what we hope is that you retire before this line goes down below this line. There are measured gaps in competency, particularly in individuals who practice in offices, working on teams, use of information technology, managing populations, being reflective, lifelong learning skills. All of these are things that people have been measured to be deficient in: coordinating care, being the primary doctor for a patient, leadership, management, systems thinking. As physicians, we have some responsibility to help to change and support the system so it works better, and some procedures. Even simple things like ultrasound. I mean, ultrasound wasn't around when we started practice, and now it's a standard of care. So many of us have had to learn ultrasound along the way to keep up. Bottom line is that we need doctors who are prepared for today's practice, can provide safe care in a complex environment. It's not like it was 50 years ago, who can work in teams, who can maintain their competence, and who possess a number of skills that go beyond knowledge of a disease. Those are the communication skills and things like that. So I would suggest to you that we need to consider a change. We need to consider a change because there is a public demand for accountability. It's certainly a concern. In most countries, the public is paying our bill, so the healthcare bill. There's a concern over that gap between how a graduate can perform and the requirements that they have for practice. And finally, I think there is a real desire on our part as medical educators to improve both education and healthcare outcomes. And the two go together. You improve education, you have better doctors, you'll provide better healthcare. So let's talk about some new models that might help address these. And you might say, there's nothing new under the sun, I've heard it all before. I'm hoping to describe a few things that maybe are a little bit new to you. I'm going to describe three of them in a small amount of time and then concentrate on competency-based education. So here's four models, or four approaches, I'll say. Longitudinal models, technology-enhanced learning, social media used for learning, and competency-based medical education. So I'll briefly describe them to you. We'll start with a longitudinal model of a longitudinal clerkship. It was first, the flag was first waved in Harvard, who of course had the first of everything. This in fact is a McGill model I apologize, it's only available in French because the students who go to the place where this happens is in a French-speaking part of Quebec. But really, I don't want you to read the words, I want you to look at the picture. So, this is for all third-year students. They are attached to a region outside of Montreal in the community for their third year. And what happens is they have fairly large blocks where they have assignments to services. In this case, it's medicine and or surgery, family medicine, mental health, geriatrics, and I can't read that from here, pediatrics and obstetrics and gynecology. So they do spend some chunks of time assigned to these units, but most of their day, or at least half of their day, is spent doing a few things that are slightly different. One is they have a family medicine clinic where they actually pick up their own patients in that clinic. They have other ambulatory experiences in the medical specialties, so they're not only seeing inpatients. They have experience in the emergency room that goes all the way through. They have a little bit of experience in the hospital on an interprofessional team. They take on call. And they have a few teaching sessions along the way. But in fact, if you look at this, although it looks like these are big squares, in fact, less than half their time is spent on traditional clerkships, and more than half their time is spent longitudinally, attached to doctors who get to know them, who get to know their strengths and weaknesses, who can coach them, who then will also allow them to do more and reach perhaps a higher level than they would reach if they were changing every month or every 2 weeks. What actually happens in these clerkships, I've taken a model from another university because again ours was in French, is that the students will go to a morning clinic in a specialty and maybe even go to an afternoon clinic in a specialty, except on one day where they'll have some didactic teaching. But they will also be expected, if they have a patient in the hospital, one of the patients from their clinics, to actually go and make rounds in the morning, either on the surgical or the medical service or wherever. And they also are expected to take on call. Again, a longitudinal model. The other longitudinal model, which is a little bit more common, but does build skills and helps to build things like the doctor-patient relationship, are the longitudinal outpatient clinics that happen in residency. Particularly in specialties where you might be picking up a patient and following them along for a period of time. In my own university, we have a 2.5 to 3 year assignment to a certain clinic, usually with 1 or 2 or 3 supervising doctors. And the residents actually pick up their own patients most of the time and follow them along, make the diagnosis, initiate the treatment, and get to know the patients as they go along and see the evolution of disease. And I think this provides a very useful experience for students and residents. The next thing I'd like to talk about is technology-enhanced learning. Learning in technology-enhanced environments. I don't know whether you can see that, but it's on the slide. It says simulation, e-learning, and mobile applications. Again, this is something that the young people are perhaps more used to than some of us who've been around for a while. But this type of learning is not only for learning procedures or as you would in a simulation center. It's also incredibly useful for learning history and physical, for learning about clinical reasoning and medical problem solving, for using virtual patients or other things, learning very complex surgical procedures, Learning about teamworks, having a doll that needs to be resuscitated and having to work with a team and thinking about that. Communication skills, professionalism, health advocacy, all of those are things that can be done in this kind of a setting. And the importance of it is that, amongst other things, and particularly for more senior trainees, if you don't happen to have or to see an uncommon medical problem, you can actually learn how to manage that problem virtually, so at least you will have had some exposure to it. So most medical schools now have at least some of this. Some are a little bit more advanced than others. I would be surprised if your medical school didn't have a simulation center. Not everybody has a virtual reality lab yet. And we'll talk a little bit more about mobile applications when we move on to the next one, which is social media. How many people here are on Facebook? How many people here look at Twitter? Okay, interesting. I know in North America, virtually all of the younger people are on Facebook, and many use Twitter, and many of the more senior people also look at Twitter or other forms of social media. How do you know that what you're learning online is any good? It's not peer-reviewed. It's not the New England Journal of Medicine, right? So what a number of individuals and groups have started to do is say, let's try and make sure that what our trainees and ourselves are learning online is actually good. And this group in particular, as an example, is the academic, called the Academic Life and Emergency Medicine Alien. And amongst other things, what this group does is they look at all of the appropriate learning resources on the internet, they peer review them, and they curate them. By that I mean they organize them in some way, and they actually present them to emergency medicine residents through a, excuse me, in an organized way. So instead of your learner saying, oh, I read that somewhere on the internet, or I saw that on Twitter the other day, you can say, was it from a peer-reviewed site? Was it from Alien? And in fact, the emergency medicine docs are so sure that this is good quality learning that they actually allow 20% of their self-directed learning to be done in this way. I happen to be hooked up to this site, to the Alien people, so I'm always getting things on Twitter telling me some things that are not very useful, like how to set a broken elbow, but some things that are really keep me updated in internal medicine as well. So it's something we have to be aware of, and I think as time goes on, there'll be more and more learning via social media. Finally, and I know time is moving on, we're going to talk for a little while about competency-based medical education. I know you've had a couple of lectures about this over the last 10 years. May have been called outcomes-based education. So what is competency-based education? It's an approach to the design, implementation, assessment, and evaluation of medical education programs, undergrad or postgrad or continuing education, using the organizing framework of competencies. And most of the time, we would like these competencies to have been derived or to have come from an analysis of what society needs. So the competencies needed in Uganda or somewhere in the middle of South America may not be the same as needed in Japan. To be competent, I'm giving you 3 definitions now, because we'll be using them later. Competence is an array of abilities. It could be knowledge or skills or attitudes or a mix of them across many domains of learning or aspects of performance in a certain context. It requires you to be able to describe things. It's very dynamic. You may be competent to take care of a patient in an outpatient setting in the center of Tokyo, You may not be competent to take care of that same kind of patient in a rural setting in Africa, for instance. And clearly competence changes with time and with experience. A competency, as opposed to competence, competence is the big picture. Right? A competency is an ability of a health professional related to a specific activity that integrates all of that knowledge and skills and attitudes. And competencies are observable. You can see them, and therefore you can assess them, and therefore you can coach someone to get better. And competencies can be put together like building blocks to ensure competence, so to ensure that people develop. Is that clear? Does that make sense to you? Okay. Competency-based medical education, 3 fundamental things. Education should be based on the needs of the population served. The health needs, okay? So the primary focus of the training is the outcome for the learner. The learner should graduate with the skills and abilities to take care of that population, as opposed to the focus of education being the system, the education system, the structure and process. You're going to spend 2 months here and 3 months there and 2 weeks there. And finally, it's a continuum from the beginning of medical school into practice. And the formation continues in practice and should be integrated across that continuum. A very brief history of competency-based education. It's not new. It started back in the 1950s in industry, where they were trying to train people to do certain things and have certain abilities, and they found that they could do it in a stepwise manner. In, I think it was 1978, Bill McGahey wrote a wonderful article describing why we should consider competencies and acquiring competencies as the basis of planning our medical education. In the 1990s, the first of the competency frameworks appeared. The first one actually appeared in Canada. It was called CanMES. And it really was based on what patients expect from their doctors. About 15 years ago, many countries developed these competency frameworks, as well as Canada, the US, the UK, Scotland, Australia, the Netherlands, and I believe there's one in Japan for residents. Am I correct? A competency framework for residents? I think there used to be one. Kitamura Sensei taught me about it last time.
For the undergraduate.
For undergrads, there's a model curriculum, core curriculum, which is very big. So I'm not sure it's competencies. People started to publish about it in all kinds of fairly famous journals. And they also started to actually do something about it, to try and implement both at the residency level and at the medical school level. And we'll be talking about that in a couple of minutes. Here are some examples of competency frameworks. Notice that they're not terribly complicated. This one at the bottom this is, I think, the Scottish doctor. But ACGME in the States has actually 6 competencies. In Canada, that's in French, I'm sorry, but you can read it anyway. Professional is professional. There's 7 roles, and the College of Family Physicians also uses the same 7 roles. So these are fairly high-level domains of competence within which there may be 3 or 4 competencies. And along those, there is a continuum of levels of learning for each of them. There are many places which use competency frameworks. So Japan is in there because I really thought that there was one here. Many use CanMES, the Canadian model. Many use the American model, ACGME. there are, it doesn't really matter what framework you use, there are some common competencies in almost all the frameworks around the world. And that includes actually in nursing, physiotherapy, all the other health professions. Can any of you name any of the high-level competencies that someone might be expected to get, to acquire? Really interesting, right? Everybody's kind of looking down. Think about it yourself. What are the competencies that you, in your practice, have had to acquire? Single words.
Communication.
Sorry?
Communication.
Communication skills. Thank you very much. You know, fairly straightforward. You know, most health professionals, maybe even pathologists, have to know how to communicate. Right? Any others?
Leadership.
I didn't say where there's noise here.
Leadership.
Leadership, thank you very much. Really important. And, you know, you may not be a leader. Who said communication skills? Maybe we can have that down. There we go. And, but you often are a follower, or you're a leader of a smaller group. So here are the common competencies. They're sometimes called different things, but basically the main one is clinical expertise. You have to be competent in whatever discipline you're doing. You have to be able to solve problems in that discipline. But here, the other ones tend to be more common across disciplines. Health advocacy or prevention, communications we mentioned, teamwork, leadership, teaching skills, research skills, lifelong learning, critical appraisal, and professionalism. It doesn't really matter which framework you look at, they all have something to do with these. So there's your competency frameworks. Now let's talk very briefly about some characteristics of competency-based education. I'm not going to go into the details of how to do it this time. If you're not too scared to come back the next time, we'll talk about it again. So in competency-based medical education, the idea is to try and attain those desired competencies, and they're derived from basically societal needs, from the needs of patients, and they're organized into a framework that makes sense. Teaching and learning these competencies are basically sequenced so you can progress over time. And the learning is tailored to the individual. So not everybody is going to learn the same things at the same time. Time becomes a resource for learning. Now don't get scared by this, because almost every place that's decided to go to competency-based education has not got rid of time. They still may have rotations, but they may do different things in those rotations. But time is a resource. If you need more time to learn, you can have more time without failing. This usually means that somebody has to watch the learner, observe them, give them feedback, and coach them so that they develop over time. And so assessment becomes different both for the individual and for the system. And we'll talk about that in the third lecture. So are there some examples that actually are in place, or is this just some theoretical construct? So there are a number of examples, and I don't have all of them here. The first example in residency was at the University of Toronto. The orthopedics program went competency-based. They basically had modules that residents had to complete where they had specific competencies for surgery, but also for the other core competencies, professionalism, leadership, whatever, in each of those modules. And they found some interesting things. They've now graduated about 5 or 6 years worth of residents. One thing they found was that the really good residents managed to complete the program in about a year less than the usual traditional residency program. So I'm sure that the people that pay residents really like that. These people were considered just as competent when they got out, and they did just as well on, they still had to do the final national exam. The U.S. Has said that all of the residency programs in the U.S. are going towards competency-based education, and they have, their project is called the Outcomes Project, and there are a number of specialties. Pediatrics comes to mind, where they have developed the sequence of abilities that's needed for becoming competent. Both family doctors and specialists in Canada are doing the same thing, slightly different. I'll describe them more in the next lecture. And in Canada, there is a licensure exam at the end of medical school and a few months into residency. Every Canadian student or resident who wants to practice in Canada has to pass this exam. And the organization that gives the exam has actually decided to use the same competencies that are used in residency. That means that medical schools are now all teaching using those same competencies that we just saw. Singapore, there are a number of medical schools as well as residency programs that are either well on their way to competency-based education or starting it. In Texas, they did one better. Texas always does this, right? There's 6 medical schools that got together and said, we're going to start doing competency-based education, not just in residency at our schools, not just in medical school, but we're going to go all the way back to high school. And for students who look like they might be coming into our programs in the last year of high school and in early university, we're going to try and start teaching some of the competencies even there. And at Queen's University, which is a few hundred kilometers to the west of where I live in Montreal, in Kingston, Ontario, they are also moving to a competency-based program initially for residents, but the expectation is it'll be not only for medical students, but nursing students, physiotherapy students, occupational therapy students, so across the health professions field. It may not be as difficult as it sounds, because once you've done it with one group, you probably have some models that you can use with other groups. I think I'll skip that slide and just say, where are we now in competency-based? Using competencies makes what we are already doing, which is being implicit, it makes it more explicit. It allows teachers, learners, people who are assessing the learners to all be on the same wavelength, to have a shared understanding of what the competency is, the same mental model of what makes somebody competent. It enables an examination of what it takes and what it means to be a professional, and the ability to sequence those competencies, the learning of those competencies, allows them to be learned in a more practical way. So let's go back to the challenges. Can CBME help to address those challenges? Well, it's based on outcomes needed by graduates, and so therefore we said if some of the graduates didn't have those outcomes, then they wouldn't be practicing. Those outcomes are transparent to everybody. It also allows learners to learn at their own pace and perhaps in a slightly different order, a bit more flexible. It promotes lifelong learning. If you know you have a certain competency to learn and you get feedback, some of the things you can do is learn it yourself. It provides the needed time to learn. It allows individuals to be better prepared for those transitions, progress to the next level or into practice. And it also provides some of that public accountability. you can then stand up and say to the public, yes, I know that this person is competent. I've seen them do whatever it is. And in fact, even in the New England Journal, Lord Darcy and Garwal said 10 years ago exactly, we believe that in the future, expertise rather than experience will underlie competency-based practice. So, just a couple of words before I end on whether this might even work here, and whether we need to do it here, whether you need to do it here. There's work to do. This is a typical curriculum that I pulled off from here. You'll notice there's a lot of chunks, vertical chunks. There's no real horizontal integration of any sort, and it's very much discipline-based. Okay? And so there's a lot of work here if we wanted to introduce some competency-based programs. Now this is, I believe it's the English translation inside of the core competencies and core that are needed by medical students. Is that correct, Emma? Is that what that is? That's an English translation. It says inside something about the core curriculum for medical students. Yeah.
This is about the accreditation.
Yeah, okay, but in there, there's a whole list. And I want you to notice that it's about 1.5 centimeters or 2 centimeters thick. It's really big. And there's a lot of lists in there, words and diseases and things like that. That's not competencies. That's medical knowledge. That's not competency. So there'd have to be some work done on that. So I was thinking, what could be done in Japan over the next few years if you decided to move to a competency-based approach? One is to really work hard on having a national competency framework that's simple, that addresses the population needs in Japan. You may start off with one of the frameworks that's already there, because professionalism and communication skills and leadership and teamwork are going to be there, and as is medical expertise. But those competencies underneath them might be a little bit different. The next thing is to, if you get everyone to agree to it on the national level, it would be nice, to sequence those in some way. Not all of them have to be learned in medical school. Some will be learned in residency. Some will be mastery things that will be learned in practice. The third thing is to look at your assessment system and see how you can provide appropriate feedback, formative assessment to the learner and coach them so they do learn, and also assess them to see if they are competent, and therefore that becomes a summative assessment. And clearly all of that will take a lot of faculty development. We're at the stage in Canada now where we're dealing with the faculty development, which is one of my jobs, and it's a big job. Nobody says this is going to be a small job. But at least starting off with a general idea of what are the competencies that all Japanese doctors need, and trying to integrate them in some way into undergrad and then possibly postgrad would be a great start. So I'm ending now. Here are the key messages. I think there are some problems with our current medical education system, wherever it is, and we need to change. There are a number of new models that address parts of this. Competency-based medical education may help address some of the bigger problems that we have. And they are being implemented around the world now. It's not just theoretical. And people are learning as they go. And I think some of these concepts could be applied here in Japan that I hope would help improve the system of medical education. It is difficult to change, but not changing may be fatal. Thank you.